Thanks, Dr. Ujiki, and thanks for inviting me. Thanks, Dr. McDonald. Just non-relevant disclosure, and the other disclosure is that these are actually all my cases, so whatever you say, you're going to be judging what I did. So I have a 40-year-old morbidly obese female. She is, according to her, otherwise healthy. About 4 days ago, had severe abdominal pain after eating pizza. It's becoming more severe. She's febrile now and really can't tolerate PO. You examine her, she's febrile, tachycardic, really doesn't look well, is morbidly obese with a BMI of 61, but she is maintaining her exam is difficult, secondary to obesity. I can't tell if she has a Murphy sign or not, but she is very tender. Relevant labs, her white count is 19 and her creatinine's elevated at 2.1. Last year sometime it was around 1. The ER gets a CAT scan, decides to give her contrast. And there's, it is read as cholecystitis, some inflammation around the gallbladder, and then there's some notation of maybe lack of enhancement of the wall, but they're not definitively calling it gangrenous cholecystitis. So if we could switch to the polling, how would you grade this based on the Tokyo guidelines? So just to review, she is febrile, tachycardic, creatinine's elevated 2.1. Okay, severe. Let's go back to the slides, and that's correct. So first of all, does she have, based on the criteria, you can see here, it's really the elevated creatinine that pushes you over to make it severe. The radiologist did not definitively say it was gangrenous. However, I can tell you that it was when we did wind up going in there. But even though I didn't have that, based on the elevated creatinine, it is severe. So you have this morbidly obese female, about 4 days of pain, severe cholecystitis. What would you do after initiation of antibiotics and fluids? All right. Some controversy. And while that's coming up, maybe we can go to the panel here. Dr. McDonald, what might you do?
I think a lot of that would depend on whether I was comfortable with it and I had enough help. It was a Wednesday morning at 10 a.m. or was this Saturday night at 8 p.m. So depending on my circumstances, my help, I'd like to try to get it out, but 4 days is sort of that borderline. But if I was in a community setting without a backup plan, I would probably drain her.
Okay. Any other opinions here? Dr. Santos?
I think I would, depending on when the patient came in, really aggressively resuscitate, see how she responded. Clearly, if she's going down the tubes, I would get a drain in there. If she responded appropriately, we could correct some of her creatinine bump. She's making urine, tachycardia is improving, then I would tee her up for lap chole, depending on my resources.
All right. Can we go back to the presentation? Yeah, go ahead.
Yeah, I would agree with that. I think, you have a sick patient, but resuscitation is really important. There's some suggestion that very early surgery may be a problem because the patients are under-resuscitated. So you do have to do that. If you were really worried about her, you could go and drain her, but I think that resuscitation is really important.
Mike, do you have any opinions?
No, I agree. I mean, I think that in her case, her comorbidities are her morbid obesity and then her, renal insufficiency probably due to dehydration. So I think if she responded to resuscitation, I would, consider an early lap chole over percutaneous drainage only because, as we heard Dr. Critchlow mention, it is kicking the, can down the road. I don't see her morbid obesity, for example, changing dramatically enough to make her elective lap chole better. And now you're dealing with, inflammation, still then more chronic in nature though, but.
Right, so using the algorithm for severe cholecystitis, early laparoscopic cholecystectomy is an option, but there are a lot of criteria you have to fulfill before you can say that you can safely perform early laparoscopic cholecystectomy. There's a lot of sort of side ramps off this pathway, you have to have initial stabilization and response to those organ dysfunctions. If they are, like was said, going down the tubes, drainage and observation and further support is probably more likely. And of course, you have to be a center that can handle a difficult laparoscopic cholecystectomy, and probably the timing of the week, the day, the night is important in that decision making. All right, next case.
Actually, before we go to the next case, can I ask a question to the panel, including you, Dr. Hussain? So one of the things that really hasn't maybe specifically been addressed in the presentation so far is the patient who comes in that is maybe has some mild comorbidities, AFib, on a DOAC or on Coumadin, maybe not severe cholecystitis, but acute cholecystitis not getting better. What is the panel's typical kind of algorithm for that patient? Because oftentimes, though we might think, well, let's percutaneously drain because it might be a bit high risk to operate on a patient who's anticoagulated. A lot of times they won't percutaneously drain, and not all centers, I think, have access to the endoscopic drainage technique. So maybe I could just hear from everybody how you handle that patient on anticoagulation, Eliquis, maybe a history of coronary artery disease and a stent 5 years ago, no recent cardiac problems. How would you handle that patient? Start down at the end.
Well, first of all, I'd call for my cardiologist, and if necessary, if they need surgery and it's somebody that's a reasonable operative candidate, I would stop the Eliquis for 12 to 24 hours and then go to the OR the next day. If they were not stable or they were very sick and I needed to go that day, well, you have to take your chances. But especially in a gallbladder disease, I try to give them that 24 hours.
What if it was clopidogrel and not Eliquis?
I'm sorry?
Plavix. What if it was Plavix?
Oh, I know. That's always our kicker. Probably I would just take my chances. Again, depending a little bit on my backup, my severity, and type in crosser, and go to the OR.
Dr. Hussain, what would you do?
That's actually coming up at the next case.
Oh, okay. I'm sorry.
But it's fine. I just have a couple more points about this first case, about the timing of this patient with severe cholecystitis. I often find it very difficult to figure out how to get this patient with severe cholecystitis right on that 96-hour, 72-hour borderline about how to book the case. Is this an emergency? Do you just add it on at the end of the day? Does it depend on the day of the week? And then each day you wait, is that chipping away at your window to operate? And I think that there's good evidence from the national inpatient sample that from admission, the longer you wait, the greater the incidence of complications and need to convert to open, et cetera, are. So I think getting these patients in the operating room is quickly after that initial resuscitation is important. And I don't think we should be shy about, calling a gallbladder an emergency if it needs to be. And I find that can be very political for us.
Well, if I can just make a comment about that. I think, number one, again, resuscitation, you don't want to be going too early when they're not at least semi-stable. The other thing is, in this particular situation, this is going to be a hard one. Do you really want to, 2 in the morning versus 8 when you have your whatever staff that you have, whether you have the best athletes available? You don't want to be waiting forever, but I think that a little bit of time to try and get and optimize that situation, if that's the road you're going down, would be important. At least I would like to have my good staff there and not somebody who's kind of covering.
Right. I think that. Sorry. Go ahead. I think the patient's obesity. I was wondering if anybody takes that into account. I often get referred gallbladders. I'm a bariatric surgeon as well, in the morbidly obese patients because other surgeons don't feel comfortable, don't think they can pursue it laparoscopically. This is a NISQIP sample stratifying gallbladders based on patients' obesity. Only a small percentage were super morbidly obese, that's a BMI over 50. But what they found was that the super morbidly obese have a tendency to be booked as open, so an intended open gallbladder, which is interesting. but it's really not the obesity that contributes to the increase in complications. It's really the open surgery. So if laparoscopic surgery is possible in these patients, it should be done. Does anybody have any opinions about the obesity?
No, I agree 100%. I think, you know, you avoid a lot of wound complications, obviously keeping the incision small. So I think that was old school thinking.
I think there's some tricks that you definitely need to employ in those patients. So I think it's not unreasonable if you don't do a lot of difficult gallbladders to, you know, try to get somebody with those tricks to do these cases. They're definitely not always easy.
All right. So this next case is a case that sort of Mike was alluding to. Is a 76-year-old female, 2 days of worsening pain. And she does have a history of a recent coronary stent, drug-eluting, and she's on dual antiplatelet therapy. She's febrile, mildly tachycardic, but otherwise well-appearing. She does have a Murphy sign, but is not overtly septic. Elevated white count, mildly elevated creatinine. CT scan shows inflamed gallbladders, stone right there at the neck, a little dot of air there as well. So again, we can go to the polling. What is the grade in this patient? Some controversy there. And go back to the presentation, please. So this would be moderate. This person doesn't have overt hypotension, organ dysfunction, et cetera, but she does have, you know, potentially emphysematous cholecystitis. It's not really quite the wall, but there is air in the lumen there, and she does have, you know, elevated white count, et cetera, but it's really the imaging findings that pushes you over to the diagnosis of moderate. So in this patient, she's on Plavix and aspirin. She has moderate cholecystitis. Who would operate on this patient? Oh, nice. All right. Any opinions from the panel, Dr. Santos?
So I think we're all, you know, a little bit reluctant to operate on these dual antiplatelet therapy patients. Generally, I'll try to, you know, even give them 48 hours if I can, just to try to get some of that effect off if we can. If the patient can't come off of it, then you're sort of stuck. But, you know, certainly I think lap versus open has an advantage here, even those patients, because I think you get less bleeding with the pneumoperitoneum compared to an open approach. So, you know, I'll just wait 48 hours if I can, and then hold the Plavix. I don't have a problem with aspirin at all, but I think these patients are better served with lap-chole, and I don't really think waiting 7 days for the full med to wear off is going to get you anywhere except a much harder operation.
All right.
All right, I think we're going to have to move on. Thank you very much for your presentations. They're very helpful.